Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here with my incredibly snazzy, very couturier co-host, Dr. Jay Calvert. How are you?
I am doing very well, and I did put on clothing today, and at least 12 people said, like, what's the occasion? What's going on? What are you doing? Like, wow, you look really good. I was like, I'm wearing clothes.
I'm just wearing
I'm not wearing
clothes.
my pajama scrubs, which I usually have on.
Yes. Well, you look very nice. Thanks for doing it up for us here tonight.
It's an important topic.
Thank you. Thank you for bringing it to this podcast because this is a topic that is very near and dear to my heart. I do it a lot and I enjoy it, and it is breast reductions. So this podcast is going to be just a collaboration of everything breast reductions, what you need to know, who gets a breast reduction, what you can expect, and what are the outcomes. So we're going to hit all those highlights as we go through it.
So who does get a breast reduction? Obviously somebody that needs their breasts made
Reduced.
smaller. I think that's pretty basic. But what tells you that you're a candidate for this operation? What says I need to go see Dr. Rovelo and get a breast reduction?
You know, these patients, God bless them, they know who they are. They have usually known since they were teenagers, hit puberty, completed puberty, that they do not like the size of the breasts. It's not something that just came up on them out of the blue. But usually, for whatever reason, I do get some young patients, but sometimes I get patients in their 50s that have wanted to do it their whole life, and for whatever reason, finances, kids, life, whatever, haven't gotten around to it, and now's their time. So usually these patients very much self-select. They come in with various complaints, but usually it's, I don't like the size of my breasts, they're too large for my body, and 9.8 times out of 10, they cause pain and discomfort. So the weight and the size of the breasts are contributing to neck pain, shoulder pain, back pain. They have what we call painful shoulder grooving, which is when the bra straps dig into their shoulders and are incredibly painful and actually leave permanent indentations in their shoulders. So all of these things contribute to bringing them in and saying, I really need these breasts to be smaller.
Yeah, and there are other symptoms, too, associated. You can have sort of intractable rashes in the skin folds, the breasts being on your, lower thorax and abdomen, it just causing skin on skin irritations that you have to use antifungal, medications. There's, the symptoms of pain with exercise. There's all this, litany of issues that come up because there's, I always liken it to say, people say, well, why would they need their breasts reduced? I said, well, why don't you do this? Go to the gym, get 2 8-pound weights, tie a rope around them, wear them around your neck all day, and you talk to me about how much pain that causes.
Literally. And that is, I'll get to how much weight we take off, but we're talking on the order of pounds here. Yes, literally just hanging off of your shoulders. So these patients generally know that they need something done. And I want to touch just briefly, because I don't want to get into this too much, but the insurance coverage of this, because there are certain hoops that you have to jump through in order to be covered by insurance. One of them is you come in with those symptoms. So you come in and you say, I have the back pain, the neck pain, the shoulder grooving. You have to demonstrate that you've tried conservative measures to address those problems. Chiropractor therapy, physical therapy, my favorite, a good support bra, as if these women are going around like freeballing it without support bras.
I mean,
clearly written by a man.
Yeah, I think they're wearing a bra.
I think they're wearing a support bra. So you document that they have these symptoms, that they've failed other kinds of therapies, and then like the ultimate question, how much weight is going to be removed? And this is a very formulaic thing. It's based on what's called the Schnur scale. It goes by your height and your weight. This gives you a number called your BSA, which is your body surface area. And then it's just, you plug it into a formula. And if your body surface area is 1.7, then you have to remove, 400 grams. I'm kind of making these numbers up. If your body surface area is 1.9, then you have to remove 500 grams. And so it's very, very formulaic in that sense. And it's insurance trying to weed out the people that are coming in more for cosmetic breast lifts and don't really need a lot of weight removed, as opposed to people that would actually benefit from having a larger amount of breast tissue removed. And so those are the requirements put in place by insurance. And if you're trying to get insurance to cover it, you got to meet those requirements. It's kind of that straightforward.
Yeah, and I can save everyone a little bit of time because if you want to know what the requirements are, you can look at your insurance card, take it out of your wallet or your purse or wherever you keep it, and look on the back, and there is a website that you can go to, and you can go on the website of your insurance company, and you can see what it takes to cover breast reduction. It is on the website, and there are the criteria in black and white that you can read, and if you meet them, then the chances are you'll get approval to do it.
Right.
The one big question that will elude you or be elusive to you is how much weight you do need to remove.
What does that
because
mean? Yeah.
This is the big issue, because insurance literally, very literally, will look at the pathology report, and if they said you need to take off 400 grams, did 400 grams of breast tissue per breast get to the pathology department and get weighed in? It is really bizarre. It's kind of a like knuckleheaded, requirement, but it's reality.
It's reality, and I've had one instance earlier in my career where I was supposed to remove 400 grams, and I think I removed like 325 or something. Insurance denied it. So even though I was looking at the breast and I was like, I can't take any more. It's not going to make a pretty breast if I take more. So I made the judgment call to not deform the shape of her breast. And she ended up getting it worked out and got a deal with the hospital, and it ended up sorting itself out. But in the beginning, she got this giant bill because insurance was like, nope, didn't meet the requirements. So they are very much sticklers for that. So that's where it gets tricky for the patients, because they're like, grams, what does that even mean? Like how many grams are in my breast? So I usually have patients come in, and to give them an idea, what I'll say is, okay, so if I were to do a mastectomy on you and weighed your entire breast, it would probably weigh 850 grams. And I've gotten pretty good at doing this from doing mastectomies and breast reconstructions and knowing how much breasts weigh, and from doing breast reductions. So your breast probably weighs 850 grams. According to insurance, I have to remove 450 grams. So your breast is going to be about half the size that it is now. Are you okay with that?
Right.
And usually they are. Usually they're totally fine with that. Where it gets tricky is in someone that's borderline and they're not going to make the requirement, and I don't want to say, I'm going to remove 400 grams when I know I can only remove 200. So that's when maybe insurance isn't an option and you go down a cash pay. And I like the cash pay options because then I have so much more freedom and license to just make the breast that they want, the size that they want. A breast is going to be pretty, and in the back of my mind, I don't have like an insurance man telling me I need to take more. So those are the options for insurance versus a cash pay option. And if you don't know which one you fit into, just go talk to your surgeon, and they will very quickly probably be able to tell you which category you're going to fall into.
I want to get into your results of how you do this operation. We're talking about how it's done.
Yeah.
But so I in preparation for this podcast, I went and reviewed your website and looked at your before and afters, and they are really great.
Well, thank you.
First of all, you do a lot of these, which
Do a lot.
I mean, if somebody needs a breast reduction in Southern California, there's probably like an 8% chance you've done it at this point. But that's the thing, is they look really great. Your scars are beautiful. The shape is incredible. You get a really nice medial fullness and cleavage. And, not all breast reductions are created equal. And especially in the insurance world, I have seen some stuff in my training that was just not pretty. Like these surgeons were just like, it's a breast reduction. I'm just taking this tissue off, and we're going to close it up and get out of Dodge. And this is sad to say, and I know when I say this, there are like probably 148 people who went to the University of Pittsburgh who know exactly who I'm talking about. One of the surgeons stapled the wounds closed.
Oh, gosh. Oh, good grief. Okay, people, we don't do that. We do not staple the breast. That is a one-off. We don't do that.
Well, that's how this surgeon did it. And right now, everybody at Pitt is like, I know exactly who that is. But, whatever. They felt it was a functional operation. And there's like, it's not aesthetic to them.
Here's the thing. And so this is where insurance becomes obnoxious. Because for better or for worse, the surgeon that does a beautiful breast reduction and the surgeon that staples the breast get paid exactly the same from insurance.
Exactly the same.
Insurance could care less if you have a beautiful result or if the weight was just removed and you were closed. There is no differentiation in the reimbursement. So there is not a lot of incentive for some people to spend 5-6 hours doing a breast reduction because they're not going to make any extra money for it. So in that sense, sometimes going to someone and just paying them cash is a better option, not all the time, but sometimes, because that person is taking your money and is going to want to do a really nice job for you because they can charge more and charge for it. So these are the ins and outs of an insurance and plastic surgery world meshing. And so, as we say time and again, go and look in the befores and afters. If you like what you see, it doesn't matter if they're in insurance or not. Clearly, that surgeon is taking their time to make a pretty breast, regardless of whatever payment they are receiving.
Yeah, I mean, when I do my breast reductions, I don't take insurance, so it's all cash, and you bet your butt that I am going to be making it look beautiful. I want them to love the breasts that I make for them.
Me too.
And you clearly do, and your results are spectacular. And that's the thing that I think people need to understand is that you have to look at those before and afters.
You got to look at them because that's what you're going to get. So here we are. We've decided we need a breast reduction. We've gotten approval or we're paying for it. We've picked our surgeon. How does it happen? What's the next step? So breast reduction is a surgery that you come the day of, go home the same day. So it's an outpatient procedure. I tell patients you're going to have a couple days of pain and discomfort, but usually by days 2, 3, 4, they're off pain medication, maybe on some Tylenol, some ibuprofen. They're moving around. They're getting back into their daily life. People that have desk jobs, or sometimes my students, they're back to work, in a week or so, and that's okay. People that have heavy lifting jobs, so nurses, any kind of heavy laboring, factory, whatever, 6 weeks, because you really need that full time to allow these incisions to heal. Because these incisions are what people really have to wrap their mind around. And if you're coming in for a therapeutic breast reduction, meaning you're doing this because you have large breasts that really need to be reduced, there's no way around the incisions. The incisions are an anchor pattern scar. That's an incision that goes around the areola, so the areola does get reduced and made smaller, down the center of the breast, and then underneath. That underneath scar, I don't care about because literally you don't see it. No one will ever see it. If you're looking at yourself in the mirror, you see the ones that go around the areola and down the center. That being said, I say give it about a year. Most of these scars do fade pretty nicely. Scars we don't like, we have options for scar revision, scar treatments. But if you want the breasts reduced and you want them lifted, you have to do the scars. Which brings me to the thing I know I'm going to talk about next, because I get the question all the time. Do I get a lift with a breast reduction?
Everyone asks that.
Do I get a lift with a breast reduction?
No, we're going to leave your nipples pointing at the ground.
We're just going to scoop out some tissue and call it a day.
Yeah.
But if you don't know, you don't know. And there's the way we do breast reductions, the way everybody does breast reductions, the way the pattern is designed is called a WISE pattern. It incorporates a lift into it. So that means, to be clear, this is really a nipple areola repositioning. It's coming back up to a higher position relative to where it is in space and relative to where it sits on the breast. What it's not doing is giving you an implant look. We're not pushing your breast tissue up to your clavicle. It's not that kind of lift. It's just a repositioning and elevation of the nipple areolar complex, and that is built into the procedure of a breast reduction. So you have your breast reduction, you have these incisions. I see my patients, the next day, and then at a week, and then 3 weeks, 6 weeks, etc. And the incisions, I keep them covered for 2-3 weeks with Steri-Strips. Patients don't have to do anything for them. There's no wound care really to be done at home in the beginning. You just have to wear your post-op bra and take it really easy. That being said, days 10 to 14 are kind of a witching hour for incisions, particularly where that vertical incision meets the horizontal. That's called the T-junction. Prone to breakdown in that area. That is the area of your incisions that have the highest amount of tension and the least amount of blood supply. So not unusual to get a little bit of wound separation, 5 millimeters, 6 millimeters at that T-junction. You put some antibiotic ointment on it, it heals on its own and it's just fine.
And it's very superficial.
It's very superficial.
Yeah, it's not
short of that,
a problem.
Yeah, there's not much wound care that you have to do. I don't use drains, but people ask me all the time about drains. I don't know if there's still surgeons out there that use drains, but I don't put drains in my breast reduction. Oh gosh, do you put drains in your breast reduction?
No,
Okay.
I think I used to. I don't really do that much anymore because I don't know what they're doing for me.
I don't either.
Yeah, I think the concept was that if you had a lot of fluid buildup, but you really don't.
You don't. I've never seen a need for it. It's never been an issue.
No, and I do pillar sutures and close the dead space.
Yeah.
That makes a big difference. So you don't need drains.
No, you don't need drains. So there's no drains. The care of the postoperative care of your breast is quite straightforward.
Yeah, and the dressing, typically I put my patients in a surgical bra. I might do a little wrap just for extra compression, but it's really pretty straightforward in terms of the breast is a skin gland. So, we're not going into body cavities, like we're not operating around the lungs or...
Nope, we're not doing anything with the muscles.
Yeah,
so it's a skin, it's a superficial surgery. Now, I do a fair amount of liposuction with my breast reductions. So this is on the sides of the chest wall, not really breast tissue. Usually it's just extra fat that people don't like. So have a hard time calling it breast tissue. It's just a little extra fat. But while we're there, not uncommon to do a little bit of liposuction on the sides. Also up top, kind of in that armpit area where there's like some armpit fat, I will do some liposuction up there as well. And those areas are the ones that tend to stay sore longer than the breasts themselves from the liposuction.
Yeah, and you can get seromas there too, especially in the armpit. The armpit lipo is kind of important though, because otherwise you have these reduced breasts and then there are these like puffs sitting in your
there.
arm.
It really ruins the result.
It's not cute.
It's not good for the before and after.
No, you want to definitely get those out.
So you got to fix those.
But that's extra cost, especially if you're doing an insurance reduction. The insurance isn't going to pay for the lipo, so you got to come up with some extra bucks for that.
For the liposuction. And then that's it. And what I love about this surgery is that day one, 12 hours from their surgery, because if I do this at the hospital, they keep them for like forever and discharge them at 10 p.m. And then they come see me at 10 a.m. the next morning, and I'm like, how are you feeling? And they're like, I think my last patient said, I feel simultaneously awful and amazing. She was like, her breasts were sore. They were causing her problems, but her neck, her back, her shoulders had never felt so good. She's like, I woke up for the first time ever without being in pain. She's like, is this how everyone feels just walking around? I was like, kind of,
That's the deal.
Yeah, so, and I hear that all the time. Like the pain that I was having before, it's gone. The moment they come out of anesthesia, it's gone. And it just continues to get better. So that is the benefit, huge benefit of these breast reductions, is the immediate sense of relief they have from all of the symptoms they were having before.
What about loss or alterations of nipple sensation with this operation? How frequently do you see that? Pretty common. So most people have decreased sensation to the skin of the breast and to the nipple, although some patients actually have increased sensation. Increased sensation tends to sort itself out after a few months and go away. Decreased sensation usually does, but sometimes decreased sensation can be long-term. So that is something to be aware of. Although if you have really large breasts, a lot of times you don't have a whole lot of sensation in the nipples anyways. Yeah, that's a big thing because a lot of patients say like I don't have much sensation there in the first place because the breasts are so long and
the nerves are so stretched.
They're just stretched out.
Yeah, so that is definitely something. I have had one or two patients who didn't have a breast reduction. They needed it, but they couldn't wrap their mind around having reduced sensation. I've never had anybody lose complete sensation in both nipples. Like usually something comes back and it's sufficient.
Yeah, I've had patients with reduced sensation permanently after, but they've always had something. I had one patient that did not have a breast reduction because I said, well, you could have this. This could happen. She goes, but I will not be able to have an orgasm if I don't have my nipple sensation.
Yes.
And I said, then you need to decide whether those orgasms are important to you or not, because that can happen with a breast reduction. And she did not have a breast reduction because she was like, no chance.
Yeah, I think that was a similar situation that I had with my patient. She's like, nope, that's not worth it to me.
Yeah, and that's something to consider and something to know about because it is real. I mean, I can name the patients that had reduced sensation because in general, they don't. In general, they're totally fine. And I've done probably 400 reductions in my practice. It's not something I do that commonly, but it's, since
That's a decent number.
Yeah, it's a decent number. I've done a lot, and they come when they come, and the reality is that I always go through the same consent, and I kind of say, look, these are the things that actually happen. Wound issues at the T-junction, alterations or loss of nipple sensation can occur, and then the scars. And that's sort of the reality of it. Size mismatches and stuff like that, those things can happen, but they're not. We're pretty good at getting them close enough. And breasts are sisters; they're not twins.
They're not twins. Yeah, the size is not. I think the three things you mentioned are the things that I usually talk about. The biggest, the thing I worry the most about is blood supply issues to the nipple, because these, we cut these nipples around completely. We do not cut them off. Sometimes we do, but that's
pretty rare.
That's a whole different procedure, and that's called a free nipple graft, and not what we're talking about today. In general, the nipples are still attached to breast tissue, but we release them from all of the skin, holding them in place. So we're doing big moves with them. We're moving them 15, 18 centimeters sometimes, and so sometimes they don't always like the journey and the trip. I've only ever had one complete loss of a nipple. It was in a very large patient who was actively smoking, and I told her that she was going to lose her nipples, and she said, I'm okay with that. I can't stop smoking, but I need this breast reduction. I go, all right. Well, she kept one, and then the other one died, as we kind of assumed it would.
You had to make her a new one.
We had to make her a new one. She didn't care.
She just wanted the reduction.
It dies, but then when it heals, it scars in the shape of a circle, and it looks like an areola. Yeah. So most people are like, it's fine. But every once in a while, I'll have nipples that have little patchy areas that don't survive or kind of form a scab and then falls off and heals from underneath. Any scars we don't like, any little wound healing areas we don't like, we can revise and do little scar revisions in the office. So that's an easy thing to handle. And then other than those things, everything else is pretty much a straightforward recovery. Very, very happy, very, very satisfied patients.
Yeah, the satisfaction level of a reduction patient is very high, and it's a very popular operation. It's common. We do a ton of them. I don't do as many now. I have somebody who's a real expert, so I would defer to your knowledge on the reductions, especially you're doing so many of them so frequently. And the reality is there's a lot of artistry involved, and that's what I always liked about reductions is it's an opportunity to take something that's not looking so hot to begin with, and you can really make a beautiful breast if you manage the tissue well and you manage the blood supply, get those skin flaps just right, and obviously I do a lot of this with my breast lifts, but the reductions I think are kind of more your game.
And I enjoy it. And I take my time, and everyone in the OR and the hospitals can attest to that.
Yes.
Sorry. But you know what? You're welcome. Because if that was you on the table, you would want me to take my time and make the prettiest breasts possible, because that is what it's about as well. And then the long term with these breasts, I do them sometimes in very young patients. The breast can continue to grow with changes in hormones, so birth control pills, pregnancy, breastfeeding, menopause, weight gain, weight loss, all of these things can contribute to size changes of the breast. They will never go back to the way they were before. They will more or less keep their shape, keep their position, keep their elevation, but you may see some changes in the looseness of the skin and the size of the breasts with these changes. But I think, closing thoughts, what I hear with these patients is my symptoms are vastly improved, if not gone. I'm so glad I did this. I wish I did it earlier. And that is, I hear it every week. I wish I'd done this earlier. I'm so glad I did it.
Well, you are an expert. And, if you're interested in this operation, obviously, check out Dr. Rovelo's Rovelo Plastic Surgery website, because she is amazing. But on top of it, if you're looking in your part of the world, find somebody that's really good at it.
Yeah.
Look for somebody that is, an enthusiastic, breast surgeon that is going to do a great job for you. You want somebody that's into this and isn't going to staple the wounds closed.
Yes. Run far away from that.
I'm going to catch so much flack for that. I know it's coming any minute now. University of Pittsburgh, you all know who you are.
They're coming for you.
They will. It's okay. Pitchforks and torches and... Yeah, there is. You shouldn't have talked about that.
Well, we're not going to end this podcast with staples. We're going to end the podcast talking about the beautiful breasts that you can have and the pain-free symptoms that you will have after your breast reduction. So if you're at all thinking about it, go in, find that plastic surgeon that works for you, and check it out. See what you can do.
That sounds very good, Dr. Rovelo.
Excellent. Well, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.